Continue with colonic polyps. Colonic polyps are divided into non-neoplastic polyps and malignant polyps. So non-neoplastic polyps are hematomatous polyps. Actually, they are solitary polyps. Just they're having some disordered architecture in the colon tissue, and that is causing this. They are otherwise benign. Okay. So they are associated with some syndromes like Peutz-Jeghers syndrome, juvenile polyposis. Okay. Next, coming to hyperplastic polyps. Actually, they are benign polyps. They are most common and they are smaller, located in rectosigmoid junction. They occasionally evolve into serrated polyps and sometimes into more advanced lesion. They are actually short tooth or serrated pattern. Next, inflammatory pseudopolyps. They are due to mucosal erosion due to inflammatory bowel disease condition. Mucosal polyps are small, less than 5, and they look similar to normal mucosa, but they're clinically insignificant. Actually, all these are non-neoplastic, like they're benign. Okay. Submucosal polyps may include lipoma, leiomyoma, fibroma, and some other lesions. Next, coming to malignant, they are adenomatous polyps and serrated. Actually, according to the shape, they are divided into two types. One is sessile, that is having a broad shape. Here in this diagram, you can see this is sessile, and the other one is pedunculated. You can see some outgrowth like structure. It is having a stalk. So they are like neoplastic because of chromosomal instability pathway with mutations in APC and KRAS genes. They are divided again into tubular and villus. Actually, among this tubular and villus, the villus is more dangerous. You can say this is a villus pattern, which is more dangerous, more malignant. This is a tubular pattern, and in between them you have another pattern, that is a tubulovillus pattern. It is intermediate malignant potential. Usually they are asymptomatic, but sometimes may present with bleeding. Okay, villus adenoma have increased mucus secretion, so it may cause secretory diarrhea, and it causes hypocalcemia because in diarrhea there is loss of calcium. Next, serrated polyps are neoplastic. They characterized by CpG island methylator phenotype, that is CIMP. Cytosine base is followed by guanine, and it is linked by phosphodiesteride bond. Defect may silence mismatch repair gene, MLH1 expression. Mutations will lead to microsatellite instability and mutations in BRAF. It will cause sawtooth pattern of Krebs on biopsy. Up to 20% of cases of sporadic colorectal carcinoma is associated with this. Next, there are different polyposis syndromes, that is familial adenomatous polyposis, which is autosomal dominant. There is mutation of APC tumor suppression gene on chromosome. You can see 5q21 to q22, and it is two hit hypothesis. Thousands of polyps arise starting after puberty. Pancolonic always involve rectum, prophylactic colectomy, or else 100% it can progress to colonic rectal carcinoma. Familial adenomatous means already they're having one gene of APC suppressor gene, then the second one is ready to come. So always they have a chance to form this polyp. So and before prophylactic colectomy is better. Next, Gardner syndrome, FAP. That is familial adenomatous polyposis, along with some osseous and soft tissue tumors like ostium of skull or mandible, and some congenital hypertrophy of retinal pigment element. It is impacted or supernumerary teeth are also present, skin cyst and CT growth. Next, coming to Homer Wright Rosette Turcot syndrome. Here also this FAP or Lynch syndrome or malignant CNS syndrome like medulloblastoma, glioma, Turcot, turban. So how to remember turban? Head on head you will have medulloblastoma, glioma, right? So that's why Turcot syndrome is associated. Gardner means just remember like a garden. In the garden, especially bone garden, okay, because there are bone problems, bone cyst tumors. Okay, next, coming to Peutz-Jeghers syndrome. It is also autosomal dominant, featuring numerous hematomatous polyps throughout GI tract with hyperpigmented macules on mouth, lips, hands, genitalia. Increased risk of breast GI cancer, that is colorectal, stomach, small bowel, pancreatics. Next, juvenile polyposis syndrome, autosomal dominant, children, juvenile, you can see less than 5-year-old, numerous hematomatous polyps in colon, stomach, associated with increased risk of colorectal carcinoma, common in rectum. It's pedunculated. It is auto amputate. Colon cancer screening 50 years, fecal occult blood testing, regular digital rectal exam, colonoscopy if blood detected. Next, coming to Lynch syndrome, actually it's called hereditary non-polyposis colorectal cancer, that is HNPCC. Actually here also there's microsatellite instability, there's actually right-sided tumors. There's also increased risk of endometrial cancer, ovarian and skin cancer. Actually there is a mismatch mutation of MLH1 MSH2, so that is leading to microsatellite instability and this syndrome, and this is also having a chance to go into colorectal carcinoma. Next, coming to colorectal cancer is mostly seen in females who are greater than 50 years. Not only females, anyone who is greater than 50 years. Okay, and it is mostly seen rectosigmoid followed by ascending, next descending. The screening is we should do screening for 45 years with colonoscopy. If polyp is seen, it looks like this, and it includes flexible sigmoidoscopy, fecal occult blood testing, fecal immunochemical testing, that is fit fecal DNA, CT colonography. Okay, and whenever you need to raise a suspicion is a male with iron deficiency anemia and a postmenopausal female, then we need to raise the suspicion of this cancer. Patients with first degree relative who has colon cancer, we need to screen at 40 with colonoscopy or 10 years prior to relative's presentation. Patients with inflammatory bowel disease screen for 8 years after onset. You can see the apple core lesion on the barium enema, and CA tumor marker is good for monitoring recurrence, should not be used for screening. DCC is detected in colorectal cancer. It is a tumor suppressor gene, that is chromosome 18q, frequently mutated in advanced colorectal cancer. Third most common and third most deadly cancer is colorectal and common after 50 years of age. So actually it is divided into right-sided and left-sided. Most are asymptomatic. Right-sided is cecal and ascending colon. It is associated with iron deficiency, anemia, weight loss, exophytic tumor, microsatellite insufficiency, and occult bleeding. Whereas left side is associated with lower quadrant pain, blood in stool, and circumferential lesion, adenoma, carcinoma sequence is seen in left side, that is in the rectosigmoid area, associated with hematochezia obstruction, and ascending will show exophytic mass, iron deficiency, weight loss. Descending will show infiltrating mass, partial obstruction, cloaky pain, hematochezia, and it can present with S. bovis, galactolyticus, bacteremia, endocarditis, or as an episode of diverticulitis. Next test is colonoscopy. Risk factors are adenomatous and serrated polyps, familial cancer syndromes, inflammatory bowel disease, tobacco, diet of processed meat with low fiber. So most common metastasis is to the liver. So high risk polyps are villus, dysplastic grade increased polyps, increase in number, increase in risk. Chronic instability pathway, adenoma carcinoma syndrome, takes 10 to 40 years, and most common on left side causes tumor, descending and sigmoidectomy. You know, descending and sigmoid on left side, right? So here coming to the molecular pathogenesis of colorectal cancer. So what you come to know is, whenever you see right sided, it is mostly related to microsatellite instability pathway, which is also associated with Lynch syndrome, right, where there is methylation of mutations or methylation of mismatched genes like MLH1. So it causes serrated polyp pathway, lead to right sided colorectal cancer. Okay, but whenever there is chromosomal instability pathway, it is involving left side. Okay, most common in APC, FAP. APC mutation causes familial adenomatous polyposis, and most sporadic cases of colorectal cancer via adenoma carcinoma sequence. Okay, so overexpression of COX2 was also linked to colorectal cancer. So NSAIDs may be chemopreventive. So here if you see a COX pathway lipid membrane, phospholipase A to arachidonic acid to COX1, COX2 into leukotrienes, prostaglandins, thromboxane. Aspirin therapy can be used but may increase risk of bleeding and ulcers. Okay, so let us see the APC and this chromosomal instability pathway. So first actually is a normal colon. There's decreased adhesion, increased proliferation, loss of APC gene. Now colon is at risk. So there is KRAS mutation, unregulated intracellular signaling, formation of adenoma, increased tumorigenesis, loss of tumor suppressor genes, and that is leading to carcinoma. So this is a pathway which you see on left side. On right side there is chromosomal microsite instability pathway is seen on right side. Okay, left side chromosome instability pathway, that is APC KRAS mutation. This consequence, I mean this sequence. Okay, let us understand this cirrhosis and portal hypertension. Actually, the liver, it forms a nodules. It will undergo total cirrhosis or fibrosis. So the liver function will be lost. This is mainly due to you can see the stellate perisinusoidal cell which secrete TGF beta. They produce fibrous tissue, which is a major contributor for cirrhosis. So as the liver is undergoing cirrhosis, you can understand there is increase in portal hypertension. There's lot of increase in portal hypertension. You can see a diffuse bridging fibrosis by stellate cells. Regenerative nodules disrupt the architecture of liver. Increased risk of hepatocellular carcinoma will lead to many systemic changes like many various systemic changes. Causes are alcohol, non-alcoholic steatohepatitis, viral hepatitis, autoimmune hepatitis, biliary disease, genetic metabolic disease. Whatever the disease is, because of the blockage of liver, there is portal hypertension, increase in portal pressure in portal venous system. Etiologies include cirrhosis, vascular obstruction like portal vein thrombosis, or Budd-Chiari syndrome, schistosomiasis. Actually, what is the problem here? Now, because of this, the first thing which you observe is ascites. Ascites is nothing but the fluid in the peritoneal cavity. Why the fluid has come? Because of portal hypertension, and there is decreased albumin. Together, they lead to increased water, total body water. Clinical diagnosis is cirrhosis, where there is ascites plus decreased platelets and also spider angiomata. I will show all those conditions. So actually the mechanism behind this is decreased albumin, so decreased oncotic pressure, increased nitric oxide, decreased systemic vascular resistance, that is leading to finally decreased effective volume, that is leading to increased RAS and ADH as the volume is decreased. So because of that, ADH will lead to increased total body water, that is more reabsorption of sodium and water. So this is the problem here. Let us see from the top, from the tip to what is going on. So first, if you see integumentary system, that is jaundice because liver is cirrhosis, so unconjugated bilirubin levels will be high, and spider angiomatas, palmar erythemias, purpura pechiae. Pechiae is because of low platelets. Effects of portal hypertension, esophageal gastric varices, because systemic and portal systems are connected. Already I discussed what type of vessels are connected. Okay, that is leading to hematemesis, melena. Vascular caput medusae, anorectal varices, ascites, spontaneous bacterial peritonitis, reproductive testicular atrophy, gynecomastia, amenorrhea. Why all these conditions are continuing? Because of increased estrogen. You can see whenever there is increased estrogen, it causes gynecomastia in male, spider angiomata, and also palmar erythema. All these are because of increased estrogen. Because of this, clinical features are jaundice, hypoglycemia, coagulopathy, hypoalbuminemia. You may think why coagulopathy? Because liver forms most of the coagulation factors, right? So in neurological system there will be hepatic encephalopathy because liver is now blocked. All the toxins of liver are accumulating in brain. Asterisk 6, flapping tremor. And in gastrointestinal system there is anorexia, nausea, vomiting, dull abdominal pain. And in hematological, thrombocytopenia, anemia, coagulation disorders, splenomegaly. Renal, there is hepatorenal syndrome. Metabolic, hyperbilirubinemia, hyponatremia. Cardiovascular, cardiomyopathy, peripheral edema. So mainly the TGF beta of the stellate cells is causing the fibrosis of liver and causing all these problems. And one more thing you need to see is SAG count. If the SAG count is greater than 1.1, that is portal hypertension. If the SAG count is less than 1.1, that is malignant leaky ascites. Ascites treatment, first drug of choice is spironolactone, second is loop diuretics. You can do TIPS procedure. TIPS procedure is connection of portal vein to hepatic vein, so that we are trying to decrease the portal hypertension. And we can also do paracentesis. What is MELD score? MELD score is done for 3 months for diagnosis of cirrhosis. If the MELD score is greater than 40, then there is 71% of mortality. If MELD score is less than 9, then there is 2% chance of mortality. Next, coming to spontaneous bacterial peritonitis. Actually, the same along with ascites in the liver cirrhosis, if there is bacteria entering, that is also leading to peritonitis. So that is this condition, primary bacterial peritonitis. It is often asymptomatic, may cause sometimes fevers, chills, pain, and worsening encephalopathy, mainly caused by gram-negative E. coli Klebsiella, sometimes also caused by gram-positive streptococcus. Diagnosis: paracentesis with ascitic fluid. Then you should check out the absolute neutrophil count. If it is greater than 250, then the first line treatment is third generation cephalosporin, that is cefotaxime. And the child pug score, if it is 5 to 6, then you will say it is class A. It is 7 to 9, class B. 10 to 15, class C. Class C have worse cirrhosis prognosis. Next, serum markers of liver pathology. Actually, ALT and AST are measures of liver. Okay, so A aspartate aminotransferase is and alanine aminotransferase. Alanine aminotransferase is ALT, aspartate aminotransferase AST. So actually AST is increased in most of the ALT is increased in most of liver disease, but in alcoholics AST is mostly involved. So sometimes AST is also increased in non-alcoholic disease, and it is suggesting advanced fibrosis or cirrhosis. And next fourth thing, aminotransferases, if they are greater than 1000, then the differential includes some drug-induced liver injury or ischemic hepatitis, acute viral hepatitis, autoimmune hepatitis. Alkaline phosphatase is increase in cholestasis, that is when there is biliary obstruction, there is infiltrative disorder of bone disease. Delta glutamyl transpeptidase is increased in various liver and biliary disease like ALP can, but not in bone diseases. Okay, that is important. And also with alcohol use, delta glutamyl transpeptidase increases. Next, functional liver markers are bilirubin, which increase in many different liver diseases, especially biliary obstruction, alcoholic, viral hepatitis, hemolysis. Albumin is decreased in advanced liver disease. It's a marker of liver's biosynthetic function. So if liver is getting cirrhosis or damaged, then it can't produce albumin because albumin is naturally produced from liver. So it's a biosynthetic function. Next, prothrombin time is increased in advanced liver disease because of decreased clotting factors and thereby measuring liver's biosynthetic function. Next, platelets are decreased in advanced liver disease because of decreased thrombopoietin, liver sequestration, and portal hypertension, and that is leading to splenomegaly, splenic sequestration, so decreased platelets. Next, Reyes syndrome. Actually, it is seen mainly in children who take aspirin. That's why we should not recommend aspirin to children except in Kawasaki disease. Otherwise, aspirin, because in Kawasaki disease, children are having heart problems, so we give aspirin only there. But in other conditions, if we give aspirin, that will lead to Reyes syndrome in children. That is associated with fetal childhood hepatic encephalopathy and liver failure. Why aspirin causes this dryness? It because metabolized decreases beta oxidation by reversible inhibition of mitochondrial enzyme. And one more thing, AST is present in mitochondria and liver, and ALT is present in cytoplasm. That you need to remember. For synthetic liver function test, we take albumin, PT, PTT, and glucose as measures. So next, let us see alcoholic liver disease. It is of three types. One is hepatic steatosis. In the name itself, you can see liver is getting accumulated by fatty cells that are macrovesicular fatty cells. And alcoholic hepatitis is because liver is getting inflamed because of alcohol, that too affecting the mitochondria. Alcohol is actually mitochondrial toxin, so it will elevate AST greater than ALT because AST is present in mitochondria, right? Actually, but it is reversible condition if someone stops alcohol, but actually it is caused by long-term consumption of alcohol. There is infiltration of neutrophils, and there are also Mallory bodies. You can see water Mallory bodies, that is the infiltration. Intracytoplasmic eosinophilic infiltrations are present. It is mainly due to acetaldehyde. You know, alcohol is acetaldehyde. It may cause fever, jaundice, right upper quadrant pain, tenderness. Next, coming to alcoholic cirrhosis, you can see how the liver has got fibrosis. This is irreversible sclerosis around the central vein, and it may be seen in early, and also there are regenerative nodules surrounded by fibrous band in response to chronic liver injury. There is also portal hypertension, end stage renal disease. Next, non-alcoholic liver disease. This is metabolic syndrome because of insulin resistance. Actually, it is seen only in obese patients who are having fatty infiltration of hepatocytes. You can see clearly how the fat cells are completely occluding the liver, and there is cellular ballooning and eventual necrosis. Here ALT will be greater because here in the cytoplasm the problem is not directly attacking mitochondria. Alcohol will attack the mitochondria, so it may cause cirrhosis and also hypertrophic cardiomyopathy, and it is independent of alcohol use. Let us continue with autoimmune hepatitis. So autoimmune, you can see it's a condition where our body cells are attacking on our own cells, like here in the case liver. Okay, so it's asymptomatic acute liver disease. It is causing cirrhosis. There are anti-nuclear antibodies and anti-smooth muscle antibodies. So it's actually chronic inflammatory disease, more commonly seen in females, and it is present with fatigue, nausea, pruritus, often positive for anti-smooth muscle or anti-liver kidney microsomal 1 antibodies. Labs will show increased ALT, AST, and histology will show portal and periportal lymphoplasmacytic infiltrate, because these cells are forming antibodies against it, so there will be cirrhosis in the liver, and the treatment is steroids and immunosuppressors because it's an inflammatory condition, so we need to stop that. Now coming to hepatic encephalopathy, actually cirrhosis is leading to portosystemic stents, and because of that there is decreased ammonium metabolism. Portosystemic stents, you can understand the substances which are coming to the portal circulation are directly going to systemic circulation. Actually they should undergo the process of ammonia removal in the liver, but that process is not going, so that will lead to ammonium decrease ammonium metabolism and increase accumulation. So this is leading to neuropsychiatric dysfunction, which is reversible and may range from disorientation to asterixis, that is mild to difficult arousal or coma. Okay, so triggers are increased ammonium production and absorption due to GI bleeding, constipation, infection, decrease ammonium removal due to renal failure, diuretics, bypass hepatic blood flow, post tips. If you even do tip surgery, even that in that you are trying to bypass from the liver, so there also you'll get the problem with the accumulation of ammonia. Okay, so treatment is lactulose. Actually it increases ammonium generation, and rifaximin, which decreases ammonium producing gut bacteria. Next, viral hepatitis like hepatitis A, B, C, D, all these kinds lead to increased AST and ALT, hypoglycemia. They increase the prothrombin and PTT, and they decrease the albumin. Diagnosis is viral antibody test. So liver tumors are many types. You can see here the most common benign liver tumor with vascular spaces, thrombosis is hepatic hemangioma. Let us see liver tumors. First one, hepatic hemangioma, most common benign liver tumor. In the name itself you can see hemangioma, that is it is affecting a blood vessel, mostly venous malformation, seen in 30 to 50 years type of age, and it is mainly called as cavernous hemangioma. Biopsy is contraindication because of risk of hemorrhage, because it is related to blood vessel, right? Next, coming to focal nodular, in one focus one nodule is formed, that is hyperplasia, because second most common benign liver tumor occurs predominantly in female of 35 to 50 years. It's hyperplastic reaction according to the name of hepatocytes to an aberrant dystrophic artery. Here also there is some artery dystrophy and marked with central stellate scar. This is stellate scar, asymptomatic, detected incidentally. Hepatic adenoma, a rare benign tumor related to oral contraceptive use or anabolic steroid use, may regress spontaneously or rupture, and it may cause abdominal pain, shock, solitary light rope, 20 to 40 a female. Hepatocellular carcinoma, also called hepatoma, primary malignant liver tumor. Okay, this one you can see, this is a primary malignant liver tumor. This is hepatic hemangioma. Actually you can see this is hepatic hemangioma. You can see small dots, that is because of venous malformation, and this is the hepatic hemangioma, which is the most common malignant tumor in adults. Causes are like cirrhosis of hepatitis C virus, alcoholic, non-alcoholic liver diseases, autoimmune diseases, hemochromatosis, Wilson disease, alpha antitrypsin deficiency, and alpha toxins from aspergillus. All this can cause. Okay. Findings are anorexia, jaundice, tender hepatomegaly, decompensation of previously stable cirrhosis, portal vein thrombosis. It will spread hematogenously, that is through blood. It can go either to lung or bone. Diagnosis is you do CT or MRI and you can confirm it. You can see here in the CT or MRI, this is how the hepatocellular carcinoma looks like. Okay. And next, increase alpha fetoprotein from baseline. Can also find out this poor prognosis if there's 60 to 20 meters survival from diagnosis, like 6 to 20 months survival from diagnosis. Clinical features are hypoglycemia, because this tumor use up all the glucose. Erythrocytosis is try to increase RBC. Budd-Chiari syndrome, it can block the venous outflow, and that can lead to hepatomegaly also. Okay, now hepatic angiosarcoma. it's a rare malignant tumor of endothelial origin, so angiosarcoma, associated with exposure to arsenic vinyl chloride. So people who are working in this kind of industries have high chance it will lead to jaundice and weight loss. Next, coming to metastasis, that is, it can metastasis. The most common malignant liver tumor overall is metastasis. Primary sources include GI, breast, lung cancers. Metastases are rarely solitary. Okay, there are multiple nodules in metastasis. Next, Budd-Chiari syndrome. By this diagram, you can clearly understand it's a block in the venous pathway out of your liver, so that will lead to increased pressure inside the liver, that will lead to hepatomegaly. Okay, it is mainly due to thrombosis or compression, or it is like you are compressing the venous outflow tract, and that will lead to centrilobar congestion, necrosis, congestive liver disease, ascites, varices, abdominal pain, liver failure, but there will be no jugular venous distension. It is associated with hypercoagulable states. Whenever the hypercoagulable states, any thrombus can block it, and also it is associated with polycythemia vera, postpartum stage, hepatocellular carcinoma, and may also cause nutmeg liver. Nutmeg liver is seen in right heart failure. That is also called cardiac cirrhosis, because of heart problem it is causing cirrhosis, so cardiac cirrhosis. Even OCP and pregnancy can lead to Budd-Chiari syndrome. Next, coming to liver abscess, it's a walled off infection, usually bacteremia, cholangitis, like Klebsiella enterohistolytica echinococcus. Next, Tylenol overdose. As a paracetamol or acetaminophen, if you take this, it is actually you should recommend only 4 grams per 24 hours. But if it's overdose, it will lead to hepatic necrosis, increase ALT, ALT. So you can antidote for this is activated charcoal will prevent the GI absorption, or you can use N-acetylcysteine, which is used to replenish the glutathione, and napQ1 is a toxic for liver. It is metabolized by glutathione. That's why if you replenish the glutathione, then this toxin will not form. Okay, so shock or ischemic liver necrosis is due to hypoperfusion. Clearly you can understand in shock ischemic conditions, low blood supply, so that is leading to necrosis, hypoperfusion. In this case also AST, ALT elevated, but this is a self-limited condition. Zone 3 will undergo mainly necrosis. If you remember the liver zones, okay, zone 3 is away from the blood supply, so it will undergo necrosis. It is near the central vein. Okay. Next is alpha-1 antitrypsin deficiency. Actually, it's a misfolded gene product which is getting aggregated in especially endoplasmic reticulum of hepatocyte, that is leading to cirrhosis, and there are past positive globules present in liver. It is often present in young patients with liver damage and dyspnea without a history of tobacco smoking. Okay, it is inherited or codominant. It may also affect the lung, because in lung also this protein is present. So if it's deficient, that will lead to uninhibited elastasis in alveoli. This will decrease elastic tissue, and finally leading to pan-acinar emphysema. Okay. Emphysema should usually present with the smoking people. That's why they are mentioning here. Without tobacco smoking also, if you're getting emphysema and liver damage, especially endoplasmic reticulum, then you should think of alpha-1 antitrypsin deficiency. Okay, in liver cirrhosis, pathological polymerization in endoplasmic which resists digestion with diastase. Next, coming to jaundice. Jaundice is abnormal yellowing of skin and sclera, very importantly sclera, due to bilirubin deposition, hyperbilirubinemia, secondary to increased projection or decreased clearance. We know that. So there's impaired hepatic uptake, conjugation or excretion. So you can remember hot liver, common causes of increased bilirubin level. Hot means hemolysis. Whenever there is more blood lysis, you can understand the unconjugated level will become very high, because liver can't manage that much of hemolytic products, so that will lead to increase unconjugated bilirubin. Obstruction will also lead to increase in bilirubin levels, tumors, liver diseases, all these conditions. Okay, especially liver disease also will get more unconjugated bilirubin, because it can't get conjugated. Conjugation occurs in liver, right? So these are all the conditions.